name's Mary Singer Barker. I'm one of the clinical nurse educators for the obstetrical department at Methodist Women's Hospital. Welcome. Today we're going to talk about obstetric severe hypertension and preeclampsia. Hang in there because this tends to be a long presentation. I'm not going to read everything off the slide, but we will cover a lot of material today. And we're going to take a break in the middle of this. So here are our objectives. We're actually going to talk about the pathophysiological changes related to hypertensive disorders, and then briefly go over different, we're not going to cover every classification of hypertensive disease and pregnancy, but some. What are the risk factors and signs and symptoms? Appropriate response to maternal hypertensive disease, and discharge education and warning signs related to maternal hypertensive disease. So complications of hypertension in pregnancy are both maternal and neonatal. So maternal, while the baby is still in the uterus, she may suffer placental abruption, DIC, cerebral hemorrhage and cerebral vascular accident, pulmonary edema. She may have problems with her liver and her kidneys. I know years ago we used to think the worst thing that would happen would be a seizure, but actually we look at stroke and cerebral hemorrhage and cerebral vascular accidents as probably the most traumatic things, because they not only can kill women, but if women do survive, they are left sometimes with deficits. And then on the neonatal side, because preeclampsia and hypertensive disorders are a vascular disease, it does affect the placenta, so uteroplacental insufficiency, chronic fetal hypoxemia or decreased oxygen for the fetus. You do get intrauterine growth restriction or IUGR. We get prematurity because sometimes we intervene if the host, the maternal status is not secure, and then low APGAR scores, seizures, neonatal encephalopathy, and sometimes it does result in fetal and or neonatal death. So I love this slide. This is a slide that is from the California Collaborative. Everything from the California Collaborative is free. This is from their publication in 2021. So preeclampsia and spectrum of hypertensive disorders of pregnancy, you can see that it's multifocal here. We're only going to cover some of this, and I would really encourage you to go to their website to do a really deep dive into these disease processes. So gestational hypertension disorders, gestational hypertension, you can have just plain gestational hypertension, and then you can also have preeclampsia with or without severe features. Early onset is before 34 weeks, and late onset is greater than or equal to 34 weeks gestation. Postpartum, it can happen, preeclampsia can happen, and we see that more frequently than we did in the past, up to 6 weeks postpartum, and then of course eclampsia. And then we have chronic hypertensive disorders, where chronic hypertension is diagnosed if hypertension persists after the postpartum period. And then layered on top of chronic hypertension is superimposed preeclampsia. Now, sometimes there may be a subset of women that do have chronic hypertension, but they aren't identified until they're pregnant because they don't have a primary physician. This has to do with lack or access of physician care or to the medical community. So we're going to talk just briefly about each category of these. Gestational hypertension, it is the onset of hypertension generally after 20 weeks gestation, when a woman is previously normal-tensive. The diagnostic criteria is a systolic blood pressure needs to be greater than or equal to 140 millimeters of mercury, and or diastolic blood pressure greater than or equal to 90 millimeters of mercury. Only one pressure, either systolic or diastolic, needs to be elevated. It is recorded on 2 occasions 4 hours apart. There is an absence of any kind of proteinuria or any kind of renal involvement. It's first diagnosed in pregnancy, and it does not progress into preeclampsia. That woman is normal-tensive by her 12-week postpartum visit. Formerly, this was known as pregnancy-induced hypertension, and they renamed it in 2013 gestational hypertension. I like that because it kind of pairs with gestational diabetes. However, even though we did say that it doesn't necessarily lead into preeclampsia, about 25 to 50% may develop preeclampsia. And then some women are thought to have gestational hypertension, but because, as I said earlier, they haven't had any access to medical care before pregnancy, it'll be found out that actually they have chronic hypertension. Preeclampsia, again, that the whole thought of preeclampsia has changed since 2013. And as we learn more and more, it just amazes me, because I've been in this business for over 40 years, how we used to think, oh, preeclampsia and hypertensive disorders were totally due to pregnancy and placenta. And once that condition was solved, everybody was cured. But we've realized that there are some physiological and pathophysiological things that go on within the woman, and she has long-term effects. So preeclampsia is a pregnancy-specific condition. It's not only the development of hypertension and or proteinuria after 20 weeks gestation in a woman who's previously had neither condition. It could also develop in the postpartum period. And it is not just the proteinuria. So since 2013, again, ACOG redid their definition of preeclampsia. The great thing is they didn't just focus in on renal involvement, but looked at the whole body function. So in the absence of proteinuria, they still have hypertension. They may have thrombocytopenia or impaired liver functions, or new onset of renal insufficiency, or pulmonary edema. And this last one, new onset of cerebral or visual disturbances. I think when we talk about the pathophysiology, you'll understand more about why those things happen. So diagnosis criteria between preeclampsia and preeclampsia with severe features. Hypertension, there are some criteria there. It's where the blood pressure is 140/90 times 2 different readings, at least 4 hours apart after 20 weeks gestation. However, if we have preeclampsia with severe feature, that severe feature is going to be reflected in the numbers in the blood pressure. And or 160 systolically and or 110 diastolically. Those are twice, at least 4 hours apart, while on bed rest, unless antihypertensive therapy has already been initiated, or as we know in our hospital setting, that we do our hypertensive protocols, those are within 15 minutes. We try and treat within 15 minutes on that second elevated blood pressure if the systolic is above 160 and or the diastolic is above 110. And then here we have proteinuria diagnostic criteria. Some of you, where you work, you don't do 24-hour urine specimens for preeclampsia. Some of you do a protein creatinine ratio. We do have some providers that start out with a protein creatinine ratio and then go into doing a 24-hour specimen. One is not better than the other. It's just preference. Greater than or equal to 2+ on the dipstick. I think most people have access to the protein creatinine ratio. It is massive proteinuria greater than 5 grams in 24-hour specimen is no longer a diagnostic tool. Then we have thrombocytopenia for both preeclampsia and preeclampsia with severe features. We have less than 100,000 units. And then impaired liver functions. I will just say that in each individual organization, you want to look at your lab, what your normal labs are, but usually the liver enzymes in preeclampsia are elevated to twice the upper level of normal concentration, and sometimes higher. And it can be one day, it can be normal, the next day it can be slightly elevated, and then the third day or vice versa in a number of hours. And in preeclampsia with severe features, because you have more liver involvement, you'll get that epigastric pain or that right upper quadrant pain causing liver involvement that is unresponsive to any kind of medication, or you don't have an alternate diagnosis like fatty liver disease. And then renal insufficiency. I think it's important to recognize in women that has she had prior renal insufficiency, because there are some women that do have renal problems before they get pregnant, and they can get pregnant by in vitro or other measures where before they weren't able to. So this is in preeclampsia, it's a new development of serum creatinine that's greater than 1.1 milligrams. In the absence of any other type of renal disease. And then for preeclampsia with severe features, we're looking at that serum creatinine, but we're also looking at progressive renal insufficiency. Pulmonary edema, important, can be in preeclampsia or preeclampsia with severe features, and then cerebral visual disturbances. This is new onset, not responsive to medication, or due to a sinus headache or migraines or things like that. And the same goes for preeclampsia with severe features. And I will say sometimes this is very subjective for the woman, and it's very, very hard to diagnose. And common lab changes, I'm not going to go over those specifically, but you can see with my cursor here that these are the liver enzymes that we're looking at that have increased, because normally these are normal values in pregnancy, and they're increased in both preeclampsia and then HELLP syndrome. We don't always order an LDH, but in HELLP syndrome, it is a breakdown of red blood cells, and you may see that is elevated. And you'll also see in HELLP syndrome Burr cells, because that's a byproduct of breakdown of red blood cells, and that will be present. And I always kind of talk about delusional hemoglobin and hematocrit, and that's normal physiology in pregnancy. And in pregnancy, it's normal for women to have hemoglobin and hematocrit between 12 to 16 grams and 37 to 47% hematocrit. But we need to look at, if we have elevated levels, that may be an indicator of preeclampsia or some type of hypertensive disorder due to the leakage of vessels, which we'll cover a little bit later. That will become a little bit clearer. And I think we all know eclampsia is the development of a grand mal seizure and or a coma in a woman with signs and symptoms of preeclampsia that's never had any seizures before, or has not fallen or anything else like that. The thing for me is that approximately 50% occur antepartum, but they can also occur greater than 48 hours postpartum. And I think we've sometimes had tunnel vision, myself included, in labor and delivery, that this was a labor and delivery problem, but it can also be a postpartum issue too. And then we have chronic hypertensive disorders. We covered the criteria there, where the blood pressure is greater than or equal to 140, systolic and diastolic greater than or equal to 90. Existing pre-pregnancy hypertension persists after the postpartum period, and usually they're on some type of antihypertensive medications before pre-pregnancy. Prior to 20 weeks gestation, hypertension is diagnosed during pregnancy, and it lasts past their 12-week postpartum visit. Now there is, I'm not going to go into this, but there is the CHAP trial that has really shed some light on how providers now treat women with chronic hypertensive disorders when they're pregnant. And that may be something that you can ask your providers to pull up and look at, but we're not going to go into that right now. Superimposed preeclampsia is chronic hypertension, and then you have layered on that preeclampsia. It is a sudden increase in proteinuria that wasn't present in early gestation, or other signs and symptoms of preeclampsia, such as thrombocytopenia, headache, blurry vision, epigastric pain, or a sudden severe increase in blood pressure. And then the next category that we're going to talk about is HELP syndrome, which the acronym just explains itself. Hemolysis, breakdown of red blood cells. It is a complication of preeclampsia or eclampsia, and it comes with a variety of complaints and exhibits common laboratory findings, elevated liver enzymes, low platelet count. The severity of the disease is really associated with the platelet count. 5 to 10% of women with preeclampsia may develop HELP syndrome. So if you've been to any of our classes, we've talked about physiological changes in pregnancy. I think this is so important for people that take care of women in labor and delivery, just to have this in your back pocket to know, hey, this is normal for pregnant women to have these things. And when they don't, is this something that needs to be investigated? So in normal pregnancy, a woman has decreased vascular resistance and peripheral vasodilatation. Why? Because the blood vessels need to be wide and open in order to perfuse that placenta. I love to think of a placenta as an end organ, and you want that placenta to be well oxygenated, well vascular, so that that fetus can get all the nutrients, oxygen that they need, and also for the placenta to take off those any kind of toxins that they develop. So the woman has decreased blood pressure and mean arterial pressures. That is normal, especially in the second trimester. She has a decreased blood pressure. She may also have some peripheral edema. And the other thing that happens is that she has an increase in blood volume. Really, what happens is the plasma compared to the RBCs are increased like to a 60-40% ratio. You have a physiological delusional anemia of pregnancy. And even though we do have to investigate if a woman is anemic in pregnancy, and clinical concepts, I'll give them a plug for their podcast. Dr. Martin does an excellent job in talking about iron deficiency anemia and treating that. So it's normal for women to have some type of delusional anemia, but not to the effects where their hemoglobin and hematocrit is drastically reduced. They do have a slight increase in their heart rate due to the increase in cardiac output. And something that we're not always real familiar with, but in pregnancy, you have vascular remodeling. That's when the spiral arterioles of the uterus, they widen in diameter, and those vessel walls become thinner. The next slide shows you a pictorial. I happen to be a visual learner, that the picture on the left is normal pregnancy. So you can see with my cursor here that these are the vessels, and then how they widen, kind of like a Dr. Seuss picture here. And this allows not only for oxygen and nutrients to perfuse in that interstitial space, intervillous space in the placenta, but also to take off some of those toxins and waste products of the fetus. So what happens is when you have this remodeling, this is also called angiogenesis. If it does not occur, as this is the case in preeclampsia, you can see how these vessels are really tightly woven and curved. What happens, you have decreased placental perfusion. First of all, the oxygen, the blood flow doesn't get to the fetus as it should. You have endothelial dysfunction and placenta ischemia. Once again, I refer to that placenta as an end organ. What happens when you have people that are adults and because of their lifestyle or genetics or whatever, they have increase in blood pressure or vascular disease, and it affects their heart or their kidneys. They develop also ischemia. So getting into the pathophysiology, for me, this is it. This is everything, because it really informs us that this is a disease process that doesn't end with delivery of the fetus or the placenta. These are meaning pathology, pathophysiology, is not the same as physiological changes that happen in pregnancy. Physiological changes that happen in pregnancy are normal. Patho is abnormal. The main pathogenic changes of pregnancy are caused by inadequate placental perfusion and endothelial cell dysfunction. That placental ischemia causes release of toxins to endothelial cells, and so you get spasms, which also contributes to poor tissue perfusion to all the organ systems, not just the placenta, but the brain and the heart and the kidneys. And it increases peripheral resistance. So in other words, the blood flow doesn't flow freely, but there's some resistance there. You get an increase in blood pressure. And when that happens, you get an increase in endothelial cell permeability, leakage, which leads to intravascular and protein and fluid loss and less plasma volume. Simply, the vessels start leaking. They don't stay. The volume of both the RBCs and the plasma, they leak out into the interstitial fluids, and they don't remain there. And to me, again, I think to all of us, we need to remember the main pathological factor isn't in the increase in blood pressure, because you could have somebody that has a really high blood pressure, but intravascularly they are dry. But it's rather poor perfusion due to vasospasma and reduced plasma volume. Again, yes, we're concerned about the increase in the blood pressure, but we also have to understand the mechanics behind it. So inadequate vascular remodeling, placental ischemia, you have injury to the cell, and that because of generalized vasospasma, you have increased peripheral resistance, increased endothelial permeability, decreased tissue perfusion. This is a cycle that just keeps happening. When general vasospasm happens, that's constricted high resistance of blood vessels from a narrow blood vessel lumen. So if we look at the pictures on the right, here's a non-pregnant vessel here. See how open the red is here? Okay, non-pregnant. So when a woman becomes pregnant, remember we said she has decreased vascular resistance. That's because it opens up more and allows more blood to flow through. I used to do an example in class where I'd have a really tiny, like really skinny straw, and then I'd have a big, if you can think about one of those big floppy smoothie straws, that's normal pregnancy. You want the vessels to be like that. Okay, and then here we have preeclampsia. So not only see how that thickens there, but also see how small that lumen is there. You have, and that causes increase in cell damage because you have more resistance, you have decreased perfusion, you have when things when the blood passes through the lumen of this vessel too, it gets injured, the RBCs clump alongside there, and they're forced through those really skinny vessels. And so you lose some of the oxygen carrying capacity and further decrease in tissue perfusion. So I really do want everybody to kind of understand, this is the meat and potatoes, this is it about preeclampsia and hypertensive diseases and pregnancy. Again, why we ever thought that this was a disease that would cure itself once we delivered, I don't know. I guess we're super hopeful, but when we look at those things, it just can't happen overnight. So what happens, the consequences of endothelial cell dysfunction, vasospasm, and decreased organ perfusion? You can have intravascular coagulation, increased intercellular cell permeability, and capillary leakage. On this next slide, even though it looks somewhat complicated, I love how it does factor in what happens with vasospasm and decreased organ perfusion in every aspect of hypertensive disorder. So here you have hypertension, but uteroplacental spasm. Well, the fetus has intrauterine growth restriction. What happens to the kidneys? Well, if you can remember normal physiological changes in pregnancy, you have an increase in glomerular filtration rate, GFR. Well, when you have vasospasm, spasm and decreased organ perfusion, you get an increase in uric acid, increase in creatinine, and you don't get as much urine because the kidneys are not functioning as they should. You get a decrease in GFR. Then we have cortical brain spasm. Remember, we said headache and was one of the signs and symptoms of preeclampsia. That's because that fluid is leaking out of the vessels, and that extra fluid is being stored in the head. And hyperreflexia, the nervous system is being overstimulated, which can lead to seizure. Retinal arterial spasm, again, the blurry vision has to do with the increased pressure in the eyes, and scotoma is just spots before the eyes. Hyperlipidemia, this actually has to do with an increase in insulin resistance of normal pregnancy, is heightened in preeclampsia because the liver is not functioning as it should. So the lipids are going to be even more increased. And liver ischemia. Women that really are very, very sick with preeclampsia, those 31 weekers, 32 weekers that come in, sometimes they'll just come in saying, oh, I just don't feel very good. I feel nauseated. I just don't feel good. I have pain underneath my right breast area. Oh, I just don't feel so great. You'll put the baby on the monitor. Baby doesn't look good on the monitor. You'll do labs and they're way out of whack. And this has to do with their liver involvement as an end organ. And then intravascular coagulation, that breakdown of that red blood cells. Anytime you have a decrease or breakdown in the red blood cells, you're going to have decreased tissue and organ perfusion. It's just not going to get to the organs that it should. And once again, remember that placenta is an organ. DIC, it's an acquired syndrome. And it's never really a primary diagnosis, results from some event, and in this case, preeclampsia. So platelet adhesion, you get low platelets because they adhere against the wall of the vessels, and then you have increased factor VIII antigen. Now, increased permeability and capillary leakage, that's where you get your proteinuria, you have generalized edema, you can have pulmonary edema, and when we talk about dyspnea, you may have women say, oh, I'm pregnant and I'm short of breath. If somebody comes in and says, well, I'm pregnant, I'm short of breath, okay, and they're talking like this normal, that's not necessarily dyspnea. But if they come in and they are talking like this, and they have just walked from their chair in the lobby to your area, they have shortness of breath, okay? Then that should prompt you into asking more questions. Oh, okay, how long have you been short of breath? How do you sleep at night? Where do you sleep at night? All those things. And then hemoconcentration, an increase in hematocrit, once again, because that extra plasma is not staying within that vascular system. So the following cell dysfunction slide is just the same information, but in a different format. This was adapted from information that we got from A1. So I really do encourage you to really think about physiological changes in pregnancy, what's normal, so that you can identify what is abnormal in pregnancy when it comes to preeclampsia and hypertensive disorder diseases. So here are risk factors for preeclampsia. Nulliparity, you can read those. Really, pregnancy of a new genetic makeup. In other words, paternal history. A father of a baby previously who fathered a preeclamptic pregnancy in another woman, chances are that woman may also be at risk for preeclampsia. In itself, in vitro fertilization, assistive reproductive technology. I know when I first heard this, I thought, oh, well, it's because women have they're older and they have more comorbidities. It's actually due to the actual reproductive technology, that assistance itself has nothing to do with the comorbidities. They've done studies on that. And then personal or family history. You may have somebody that's older, like myself. Women my age may refer to, oh yeah, I was sick, but I had toxemia. If anybody says, oh yeah, my sister had toxemia or my mom had toxemia, that's the same thing as preeclampsia. These are other things like gestational diabetic and things like that. You can read through those. I do want to make it clear that it really is important to distinguish whether or not somebody has a pre-existing renal disease. So predicting preeclampsia, unfortunately, fortunately, it is a condition. It's unique to human pregnancy. It does occur. It seems more than 2 to 7% of pregnancies of healthy null-parous women, but it may seem more because we have multiparous people. It may have a genetic component. As I said earlier, the paternal factors, there's no legitimate at this time screening device. And really the best practice is early and consistent prenatal care. So those of you that have friends that are wanting to get pregnant or have pregnancy, early prenatal care is the key. So we talk about level of risk, whether it's high, moderate, or low. So these are the high risk. History of preeclampsia. Multiples have an even greater risk of preeclampsia if they have chronic hypertension, all those renal disease, autoimmune disease. Those are all high risk factors in preeclampsia. So the recommendation, when we talk about recommendation, is, and the next slide goes into actually the dosage of it, is low dose aspirin. And then moderate pre-pregnancy BMI greater than 30, and I would say most people qualify for that. But if consider low dose aspirin if the patient has more than one moderate risk factor. And I will say, just because myself and colleagues work at the bedside, I see more and more women come in on low dose aspirin where they haven't necessarily had any of the high risk, but it's more moderate risk, a couple more than that they have more, 2 or more moderate risk, greater than 35 years of age, and then also with COVID thrown in there. And then low previous uncomplicated full-term delivery. They don't necessarily recommend low-dose aspirin, and here's the dosage. We like to, the providers like to start the aspirin between 12 and 28 weeks, usually before 16 weeks, and they continue until delivery. Okay. And then additional methods, we do encourage regular prenatal exercise, moderate intensity, and some refer to calcium supplements, though it's not currently recommended in the United States. However, if somebody's calcium intake is really low, or dietary calcium intake is really low, they may supplement that also. So here are signs and symptoms of preeclampsia. Of course, we've talked about hypertension and proteinuria. We've talked about edema in the face, hands, rapid weight gain, frequent headaches, visual disturbances. Epigastric pain and stomach or right upper quadrant pain. I think when you're asking patients about this, it's easier if you just say, do you have any pain under your right breast area? It doesn't go away with my Lanta or Tums. Because if you say epigastric, they're not going to know what you're talking about. And nausea or vomiting, we talked about shortness of breath. And I think it's important, very, very important, when you are triaging a patient at all, to do INO, but especially to look at their urine when they come in. And if they're coming in for if there's any inkling of them having a hypertensive disorder, look at their urine, see what color it is it concentrated looking, things like that. And then hyperreflexia, we always in our classes encourage people to do reflexes on everybody, just so you get good at it. And then this next slide, I think in our other presentations, we follow CMQCC's guidelines with the readiness campaign. And this is a screening tool that's integrated with the MUSE, the Maternal Early Warning System. Signs at Methodist Women's Hospital, we currently do blood pressures that are greater than equal to 160 systolic or greater than or equal to 110 diastolic after 2 readings 15 minutes apart. They fire an alert for an action, which we'll show you those slides. And we have a Cerner system in which we document. We'll show you what the nurse sees. And then also pulse oximetry of less than 95%, because we know that we need a pulse oximetry reading of 95 minimally, be an overachiever, to perfuse the fetus. So the next couple of screens are really going to be specific to Methodist Women's Hospital, and I apologize for outreach people if you don't use the Cerner system, but you may have something similar to this. So after a blood pressure meets that criteria, then the RN will be prompted to repeat that vital sign. She validates that vital signs in 15 minutes. If that second criteria is met, this alert screen comes up. The RN needs to provide documentation for the alert. She notifies the provider. She clears the alert, and this is the RN will document in this box, and the RN will document the intervention, initiate the protocol. And then also it gives a reminder to document any provider notification detail on that clinical notification and iView. You'll have to select initiate protocol. So here are the orders. And we use oral nifedipine, fast acting, 10 milligrams by mouth. Okay. And again, it's a medication, so you would have to have an order for that. Okay, recognize assessment essentials. I think we all know to do a head-to-toe assessment on every patient every time. Level of consciousness, you may think, oh, well, that's really silly. Everybody knows. When we talk about press a little bit later, there are some people that are disoriented, even in labor and delivery. That may be a sign of press. Deep tendon reflexes, I said this earlier, I think everybody needs to know how to do them and do them often. Clonus, headaches, visual changes. Cardiac assessment, pull out your stethoscope, listen to their heart sounds, talk about weight gain, edema, chest pain, fatigue, and then respiratory rate, count it, listen to their lung sounds, look at their skin, their O2 sat. And be aware that that O2 sat monitor is just a machine, and sometimes it's not correct. So if it somehow isn't correct, you need to document that it is or is not correct. And there are all kinds of YouTube videos too about how to assess clonus and also reflexes. And then GI wise and renal. I&O is a huge one for all of us here because it is a nursing obligation that we need on all patients to make sure that what we are giving them is also being perfused out, especially when we use IV as a resuscitative measure for in labor and delivery. So I think you owe it to your patients to accurate I&O. Okay, and then this is something that we saw when we went to an AWON conference already in 2019. Whew, it's long time ago. Was preeclampsia assessment. Your patient may be bleak. This is an acronym that helps you remember what systems you need to look at: the blood pressure, the lungs, edema, abdomen, meaning right upper quadrant pain, and central nervous system and kidneys. The next slide is going to talk about 7 simple tips to get an accurate blood pressure. This is a video, a YouTube video that you can watch, and hopefully this will work when I play it. If not, we'll give you that address. So we'll. So the first one is make sure that the patient's bladder is empty, and then you want to support the back and feet. Keep the legs uncrossed. We see this a lot with women in bed. Don't have a conversation. Talking or active listening adds 10 millimeters of mercury. And put the cuff on a bare arm, not over clothing, and use the correct cuff size. Too small adds numbers, and support the arm at heart level. Unsupported arms. So these are common mistakes that people make. And for us, I think in labor and delivery, it becomes very important because there are times that we are making critical decisions on the outcomes of that pregnancy, whether or not that person's going to be sent home or whether or not we're going to induce them. And we need to do accurate blood pressures. So these, again, are American Heart Association recommendations. And I would say too, it's important to check both arms initially to see which one is the highest, and that's the one that you go with. So you may be saying, well, Mary, okay, but my patients are in bed, they're not sitting up. That's true in postpartum area and also in labor and delivery. So we solicited our perinates to help us here. And this is what we mean by supporting the arm at heart level. Okay. And then years ago, we used to say, oh, put them on their side, left side. And you can see by these numbers here, by putting somebody just on their left side and not really supporting their arm properly, you get a false reading. The picture to the right is an accurate reading, 121/74, and the map of 88. So we want to assess for pulmonary edema if they complain of chest pain. Again, look at that O2 sat, increase in respirations and tachycardia, shortness of breath, and if they have any cough. This is an example of edema. I think you all know, first, second, third degree, fourth degree pitting edema. And then neurological complications of hypertension. Really, the key principle is that preeclamptic patients with neurological findings, such as headache, visual changes, they need to be considered to have severe features. And if they're pregnant, perhaps delivery is indicated once that is investigated. Patients with persistent neurological symptoms associated with hypertensive disorders in pregnancy need to be evaluated for stroke and press and considered an emergency, just like they have throughout the hospital. We're stroke alert, stroke certified. We need to remember that. And it requires a multidisciplinary team. We are not in this alone. The emergency room physicians are not by themselves, or nurses not by themselves. OB, we need everybody. Anesthesia, neurology, and ICU. And so we need to establish treatment algorithms to control severe hypertension, and those stroke assessment tools should be incorporated when you do any kind of education and drills to prevent morbidity from stroke. So MRI, when we talk about MRI is most appropriate in diagnosing brain lesions, and we'll talk about press. If the MRI is not available, you can do a CT imaging. And it should be strongly considered to get a neurological consult if you have a woman, whether she be antepartum, postpartum, antepartum, with a headache, hypertension, any kind of atypical neurological symptoms such as visual changes. Okay. So PRESS is a transient clinical neurological entity, and these are some of the clinical signs: hypertension, headache. They can have a seizure, altered mental state, and vision changes. There is a pathophysiology, and people can have PRESS when they're not pregnant. Sometimes it is seen in organ transplants. And what it is attributed to is a failure of the cerebral autoregulation and endothelial dysfunction. So this impairment leads to the disruption of the blood-brain barrier in that posterior circulation. And what happens is that extravasation of fluids and protein goes across the blood-brain barrier, and it causes lesions in both the occipital and posterior lobes when you see it on imaging. Early postpartum, most associated with severe elevated blood pressure and seizures, but it's usually reversible with prompt diagnosis and treatment, but you have to catch it. So you can see that these are some examples, photo examples. Show edema. This is the bright white and the occipital region. And this is the same area on diffusion. Weighted images are normal, so there's no infarction. And this is edema. There's the bright white and the occipital region. Yeah. So that is what they see. RCSV, reversible cerebral vasoconstriction syndrome. It's an entity of form of PRES. You may see this, and it's really classical as far as the person complains of like this huge thunderclap headache. And it could be associated with hypertension and neurological deficits, and that has to do with the brain edema, stroke, or seizure. And their initial CT or MRI may be normal. That's why they need to have that CTA or MRA. And what happens, they give supportive care. Clinical outcome is usually benign, but major stroke can result in severe disability. That's where we want to consult with neurology. And then stroke, of course, we know stroke from the med-surg world, but these are some things that we still have to keep in mind with our pregnant patient. We have to remember the FAST algorithm from the American Heart Association, the facial drooping, arm drift, speech difficulties, and time to activate. Again, we talked about deep tendon reflexes. You can see all kinds of, if you're not familiar with doing them, I just say do them on everybody. And I am the queen of intake and output. I think it is normal in pregnancy for a woman to start to diurese in the first or second day postpartum wise, and we need to keep track of that. And if she isn't, then we need to do discovery. Why is that not happening? And remember, if we look back at the pathological changes that happen to a woman's vascular system in pregnancy, once she delivers a placenta and the fetus, that doesn't all of a sudden miraculously heal. So keep track of that and notify providers of either the lack of output in that area. And this is just a snapshot of the negative versus the positive. So this is the void volume here. And this is the intake. So labetalol. It is an alpha beta blocking agent. It causes vasodilatation without really changing cardiac output. The onset is 1 to 2 minutes, and the peak is 5 minutes. And the duration is 2 to 6 hours after IV administration. You can also give labetalol PO. The initial dose is anywhere from 10 to 20 milligrams IV. You give it slowly over 2 minutes. Then you must wait at least 10 minutes between doses. You repeat the blood pressure if either the systolic or diastolic is exceeded over 10 minutes. You give 40 milligrams IV over 10 minutes. If either threshold is exceeded after 10 minutes, you repeat with 80. Again, you wait 10 minutes. And if the blood pressure is elevated, then you change to hydrolysine. 200 milligrams PO of labetalol can be administered if you don't have IV access and if you don't have access to nifedipine immediate release tablets. The maximum dose of labetalol is 300 milligrams in 24 hours. And you may consider switching to another agent after 140 milligrams. Some of the maternal effects are lethargy, fatigue, sleep disturbance, tachycardia, rebound hypertension. You get an increased uterine perfusion and decreased uterine vascular resistance. You may see an amplitude and frequency of fetal heart rate accelerations, but it may also lower the fetal heart rate baseline. It is important to note here that it doesn't matter if the woman gets 1 dose in labor and delivery or 5 doses of labetalol. After she delivered, you want to communicate that it can have a neonatal effect of either or hypoglycemia, hypotension, or bradycardia in the neonate. So it is excreted in the urine. So you want to make sure that you look at her renal function. It is contraindicated with somebody that has asthma, heart disease, because it's a beta blocker, congestive heart failure, of course, heart block and bradycardia, decreased dose with any kind of hepatic dysfunction or creatinine clearance. So do not raise patient to sitting position rapidly for at least 2 hours after last dose. It is, as I said before, safe for use with cocaine and amphetamine use. So now we come to nifedipine or oral. It is a calcium channel blocker. It causes systemic vascular resistance by relaxation of arterial smooth muscle. Sometimes we're asked, can we give magnesium sulfate with nifedipine? Even though it is a channel blocker, you just need to make sure that you check reflexes and things like that. The onset is between 5 to 10 minutes. It usually peaks between 30 to 60 minutes, and the duration is 4 to 8 hours. The initial dose is 10 milligrams, and this is important. It's not slow release. It is immediate release PO, and it's not affected. And if it's not affected after 20 minutes, then you can give 20 milligrams PO. If that dose isn't effective, or after 2 to 3 doses, you may consider IV labetalol or hydralazine. You shouldn't break the capsule, and you should not give it sublingually. The maximum dose is 180 milligrams in 24 hours of nifedipine. The maternal effects is it does cause a headache. You want to make sure that you can give her medication for the headache. And reflex tachycardia, it may increase liver enzymes, so keep in mind that. Doesn't have too much effect on the fetus, but avoid concurrent use. This was from ACOG and Simpson with magnesium sulfate, but again, if it's exaggerated, effect includes severe hypotension with decreased uteroplacental perfusion, maternal muscular blockade. So muscle weaknesses, jerky movements of extremities if the patient complains of difficulty in swallowing. So we want to make sure, again, that our assessments are accurate if she is on magnesium sulfate and we are giving her a nifedipine. Hypertensive medications to avoid. Some of you may or may not be familiar with these medications, but ACE inhibitors, I'm not going to go over all that, you can read that, and ARBs because of their effect, the vasoconstrictors. And then magnesium sulfate. It is a high alert medication. You never abbreviate it anywhere in the electronic medical record. It is within pregnancy our first line of therapy for seizure prophylaxis. It should be used in all patients with preeclampsia with severe features or with HELLP syndrome during labor or postpartum. It is a calcium antagonist, and it's thought to block neuromuscular transmission, depressing vasomotor center, and depressing CNS irritability. We have a loading dose between 4 to 6 gram IV bolus over 15 to 20 minutes. And then you have a maintenance dose of 1 to 2 grams. Ideally, you want to have a separate bag for your loading dose versus your maintenance dose. It should always be run on a pump, and you have 2 people looking at signing it off, making sure that all the settings are correct. If the patient continues to seize, you may give an additional dose of either 2 grams IV over 5 minutes. And if it reoccurs after the second loading dose, you may consider other anticonvulsants. Administer via controlled infusion. Therapeutic serum levels are between 4 to 7 milliequivalents per deciliters. You can administer it IM, but it is very, very painful, and 5 grams, 2 separate injections. But I haven't done that in a long, long time. So maternal effects, it does decrease uterine and myocardial contractility, decreases respirations. You do have an increased risk for dysrhythmias or rest. And that's why it's important to do bedside report and check reflexes. You may get some fetal sedation and in turn get a decrease in the fetal heart rate. Serum levels are almost identical to maternal levels in neonates. And independent double check by 2 RNs. Anytime you have an initiation, dose changes shift. It is excreted in the urine, which increases for toxicity if they have decreased renal function. It may have a tocolytic effect, so be cautious with use of narcotics or, like we said, nifedipine or any kind of beta blockers. If they have a history of heart block, myocardial damage, myasthenia gravis, renal failure, current use of CNS depressant, digoxin, neurological, neuromuscular blocking agents. So I'm not going to read all these nursing responsibilities. You can look at those, but the important thing is the calcium gluconate is the antidote that needs to be in close proximity, and then monitor for signs and symptoms of magnesium toxicity, because no longer do we do mag levels necessarily. And I would say always do strict I&Os, pulse ox, one-to-one guidelines. And on the next slide, it talks about hypotension, then absent DTRs, they get short of breath, then you get respiratory depression or respiratory arrest. And what happens next? Cardiac arrest. Those are all things that we want to avoid. So this coincides with the magnesium levels, and this is the therapeutic range. Then when you get greater than 7 to 9, that's why those patellar reflexes or any kind of reflexes, it's important to do those consistently and then show your person during bedside report what your 2+ is or whatever, because we don't want to get down to this respiratory paralysis. And I don't know about you, but I definitely want to avoid cardiac arrest. So this is CMQCC's magnesium treatment algorithm for refractory seizures. I think this is probably pretty beneficial if you work in a small outreach hospital. Also to have in your emergency room department, because a lot of emergency room nurses and physicians aren't used to this high a dose of magnesium treatment and this fast of dose. So it talks about the loading dose and what to look for, and then recurrent seizures while on magnesium and things like that. So other anticonvulsants, you can use mag sulfate, but you need to use extreme care, and you need to be familiar with the side effects and potential complications. So Dilantin can cause QRS or Q2 prolongation. So you would probably need to have her on a cardiac monitor. Okay, so those kind of things, and make sure that your resuscitation equipment is available. And these are other anticonvulsants. The other thing I just mentioned about magnesium sulfate too is initially it may decrease the blood pressure, but that is not its purpose. The purpose is to decrease CNS irritability. So inpatient management of preeclampsia, and also delivery is not cure. I hope we really solidified that earlier when we talk about the pathophysiological effects of preeclampsia. Moms need careful maternal assessment, and intensity of monitor really varies by their conditions. And we talked about initiation of hypertension agent, and this should actually be 150 or 100 on 2 occasions, 4 to 6 hours apart. You want to collaborate with the healthcare team and NICU, encourage support with lactation, monitor inpatient for at least 72 hours. So follow up with healthcare provider We're going to talk about this a little bit later. So this is about when the patient is already delivered. She is not out of the woods. And if you remember when Ashley talked about maternal mortality and morbidity, a lot of that happened during the postpartum period. So we need to make sure that we pay attention to these women. Eclampsia, again, is a prevalence, has declined due to improved medical management. And it may be preceded by warning signs, but the risk of neurological deficits and aspiration pneumonia and problems with the placenta if the fetus is still in utero during an eclamptic during eclamptic seizure is a problem. So here are some warning signs. Patients may or may not exhibit any of these: headache, blurry vision, photophobia, altered mental state, some epigastric pain. Okay, and then tonic clonic convulsions. You need to remember that when a person seizes, they stop breathing. Okay, it's halted. And then they begin again with long, deep inhalation. They become hypotensive, and then the twisting and disorientation when and amnesia may be present, and they may vomit and incontinent of urine or stool. So the most important thing is keep the airway patent, turn the head to the side, maybe place a pillow under one shoulder or back if possible. Call for help. You don't leave the patient, or get somebody to get some help. If they're in bed, you raise the side rails. If you have somebody that comes in and asks to help, direct them to fold blankets or pillows, lower the head of the bed, get your suction equipment, and try and have somebody be a recorder. We're all good at in labor and delivery, on mother baby, and the OB world of responding to emergencies. We're not great about taking ownership about what position we should take. So ask for somebody to be a runner, to be a recorder, that kind of thing. Air management in pregnant or postpartum women having seizures. Because seizures involve loss of consciousness and violent movement, you have that potential for airway obstruction, and you may have a sequela, a brain hemorrhage, fetal and maternal hypoxic brain damage due to that sensation of respiration and oxygenation. You may have some maternal hypoxia, which will lead to fetal distress. So air management in the mom, resuscitating the host is your priority. If anesthesia should be called to the bedside to secure an airway. And due to the normal physiological changes in pregnancy, you may want to remind the anesthesiologist or CRNA that a smaller tube may be needed. After they finish with the seizure, don't leave them unattended. You observe for post-convulsive confusions or coma. Again, assess the airway, and then you can give them oxygen by mask. If they don't already have an IV, you would start that and monitor for potential fluid overload. And then again, we would start magnesium if they aren't already on it. Anticonvulsants, if they're not on magnesium sulfate or they're on magnesium sulfate and it's not working, monitor fetal, cervical, and uterine status if they're still pregnant. We want to Foley because we want accurate intake and output, and then expedite lab work, provide a hygiene and quiet environment, and provide support to patient and family, and prepare to assist with birth when woman is in stable condition. I'm just going to mention HELP syndrome again. This is just a little bit more detail about that. Remember, the acronym is hemolysis, elevated liver enzymes, and low platelet count. Women often rapidly progress from preeclampsia to the development of multi-organ involvement and damage with HELP syndrome. These are the signs and symptoms. It is a high risk, very, very high risk for both maternal and fetal morbidity and mortality because of DIC, pulmonary edema, renal failure, and stroke. If she's not already delivered, delivery is required, especially if the patient is greater than 34 weeks. And assessment and management are same as those for preeclampsia with severe features. So long-term consequences of preeclampsia, I think Ashley did a really good job when she talked about the information that is available for our pregnant women now once they have delivered. But preeclampsia is a significant risk factor for cardiovascular diseases later in life, just like diabetes is, gestational diabetes is for diabetes. So we need to provide postpartum education. Do they have a primary physician that they can be seen afterwards? If they're smoking, we need to address that. Weight management, physical activity, and healthy diet. They need follow-up, follow-up, follow-up. And it should occur at least at a minimum after they are seen by their OB within 6 months, and then every year. So here are some long-term consequences of preeclampsia: high blood pressure, gestational diabetes, and preterm birth. I think this was in your information, Ashley, that they're going to be during their pregnancy if they've had problems during this pregnancy. This is all free information from CMQCC, and these are statistics that speak for themselves. So again, just because they're delivered doesn't mean that they're not going to have long-term effects, but there's some things that they can do about it too. And mothers with kids over a year also. It's a myth that all pregnancies related to high blood pressure and gestational diabetes complications go away after the baby is born. So we need to educate. I love this next slide too, only because I think some of our ED cohorts are just do a great job with triaging patients, but sometimes we miss some things. The emergency room, pregnant women call maybe their OB person, and maybe they don't think it's an OB problem, but this again is free information from CMQCC that you can post in your emergency room department. Tell us if you're pregnant or have been pregnant within the past 6 weeks. We incorporated that into our system, and it's really with, have you been pregnant in the last year? Because there could be some systems involved that really could, you go to the front line, you need to be seen. So come to the front line if you have any of those things. And then this is some of our custom patient education that pregnancy and heart disease, preeclampsia, when they should go to the emergency room, tips for talking to your provider. And another thing that I just want to mention is there is an ACOG committee opinion number 736. Again, this is the American College of Obstetrics and Gynecology that talks about postpartum care. And if you look at maternal mortality and morbidity, I used to have horse blinders on and think it was all about me, all about labor and delivery, because that's where my focus of practice was. But it's really about our postpartum patients, our postpartum sisters there too. So the primary maternal care provider, contact with all women within the first 3 weeks, ongoing follow-up as needed between 3 and 12 weeks, BP checks within 3 to 10 days, okay? High risk follow-up 1 to 3 weeks, comprehensive postpartum visit and transition to woman care 4 to 12 weeks, timing with individualized versus our traditional between 6-week visit, okay? So we need to relook at that, and we need to relook at our system and who's checking up on these women. And if it's just a follow-up phone call, or is it something where we can do better about that? Once again, I'll just mention some resources. CMQCC, California Maternal Quality Care Collaborative for families. They have toolkits. So if this is a little bit, you're just like, oh, I can't remember everything. These are websites. It's free. You can listen as much as you want. The Alliance for Innovation on Maternal Health, great organization that you can get, again, free information. The Preeclampsia Foundation is a layperson's foundation. They have information for lay people. So if a woman is experiencing preeclampsia, she can go there and she can learn legitimate information on preeclampsia. And they also have information for healthcare providers. So for me, if it's out there in the public our patients are becoming more and more informed. It just makes sense for us to be even more informed than they are. And then I love stories, but the Hear Her campaign, pregnancy-related complications can affect anyone. This is a great Center for Disease Control and Prevention. These are stories. I love a story that attaches meaning, and these are stories about women, and we all need, as professionals, providers of maternal care, to listen to moms' legitimate concerns while they're pregnant and then afterwards. So thank you for your time and attention. Here are some references that we used for this presentation.
This is a recording of cardiovascular disease in pregnancy and postpartum. It's an adjunct education to your hypertension module that you just completed. First of all, we want to start out by saying ACOG practice bulletin number 212, which was placed in ACOG in 2019 and also reaffirmed, really had a great statement about pregnancy and the changes in pregnancy and cardiovascular disease and stress. So pregnancy is a natural stress test because the cardiovascular system undergoes structural and hemodynamic adaptations. So I think it's really important to realize that pregnancy is a natural stress test, and then also that we as health providers need to understand the physiological changes that happen in pregnancy. So what are those normal physiological changes in pregnancy? This is just a review. We cover these in the hypertension module, but we want to review these. That decrease vascular resistance and peripheral vasodilatation. This decrease also decreases the systemic blood pressure and mean arterial pressures for pregnant women, and increases peripheral edema and allows for adequate perfusion to end organs in the maternal circulation. And I think in pregnancy, we need to remember that the placenta is an end organ. There's also an increased blood volume, more plasma than red blood cells, which causes a physiological dilutional anemia of pregnancy. That increase in intravascular volume, the plasma increase more than red blood cells. And then you have an increase in cardiac output. There's only a slight increase in heart rate. Most parameters will say anything above 100, 110 needs to be investigated if it's consistent. And then also in pregnancy, we have vascular remodeling. This occurs both in the myometrium, which is the muscle lining of the uterus, and within the vasculature of the placentas. They have spiral arteries in the uterus that widen in diameter. That allows more blood flow to the fetus, and then also return of CO2 and lactic acid or any toxins. Then the vessel walls become thinner, so they're a little bit more permeable. Now, there are a lot of risk factors for cardiovascular disease, but these are specific to maternal care. First of all, race and ethnicity. Non-Hispanic Black women have a 3.4 times increase as compared to other ethnicities. And I also want to say that Indigenous people, both Alaskans, Native Alaskans, and Native Americans are coming up on that disproportion or increase compared to other populations or ethnicities. Age is a huge factor. Over 40 years of age increases maternal death from cardiac disease by 30 times as compared to women that are giving birth in their 20s. Hypertension in pregnancy is also a risk factor, and obesity, especially if it's pre-pregnancy and it's associated with sleep apnea. And that comes from ACOG's practice bulletin. So cardiovascular disease in relation to pregnancy also, you have with cardiovascular disease some pathophysiological changes, meaning not physiological changes, which are normal, but disease-driven patho changes of pregnancy. They persist weeks and sometimes months after delivery of the fetus. So no longer is it acceptable to think that the patient is out of the woods or out of dangers once she delivers the baby or the placenta. In pregnancy, normally, if she doesn't have cardiovascular disease or hypertension disorders or any of the other risk factors, the heart can compensate for increased workload for both pregnancy, labor, and the postpartum period for that woman to tolerate it well. But if she has some underlying disease process, or if myocardial disease develops due to hypertension or some other processes, valvular disease exists, or maybe there's a congenital heart defect that's present, cardiac decompensation may occur. So the first presentation of cardiovascular disease in pregnancy may be in pregnancy or the early postpartum period. Usually the highest risk for pre-existing cardiac conditions to manifest themselves is in late trimester. That would be 24 to 20 weeks gestation or within the postpartum period. So we as healthcare providers should really maintain a high index of suspicion for any underlying cardiovascular disease when a woman presents with symptoms, signs, and risk factors, those 4 risk factors that we talked about, for as long as 5 months postpartum. And some literature will say up to a year postpartum. So here are the cardiovascular disease signs and symptoms that are going to alert us to further investigate: extreme fatigue, extreme swelling, weight gain, dyspnea, mild orthopnea if she's sitting up in a recliner or uses a lot of pillows to sleep, tachypnea, persistent cough, asthma unresponsive to therapy, palpitations, dizziness, syncope, tachycardia, and chest pain. So here's our cardinal rule when we talk in obstetrics about cardiovascular disease and in pregnancy is when a woman presents to any unit, whether that be an outpatient unit, an urgent care, labor and delivery unit, emergency department, and she's been pregnant or has been pregnant within the last year with any of these following symptoms. First of all, shortness of breath. And when we talk about shortness of breath, it's not somebody that is short of breath because they've gone 3 flights of stairs. We're talking about somebody that's unable to complete a sentence without taking a breath. And then the next part, extreme fatigue. We realize most women are tired or fatigued during pregnancy and postpartum because of lack of sleep. But an example of that is, are they able to complete their activities of daily living without having to sit down or to rest or without being extremely fatigued? And that has nothing to do with lack of sleep. So for instance, if she has a 2-story house and normally during her pregnancy or after delivery, she's been able to go up a flight of steps, that's completely normal. But if she has to sit every 2 to 3 or 4 steps, that's abnormal. And then inability to lie flat when resting. This takes a little bit of prompting and investigation by the healthcare provider. Instead of just saying, how are you sleeping? And they say, fine. Where are you sleeping? Do you use any pillows? How many pillows do you use? Because some women will, with cardiovascular disease, to find it more comfortable to sleep like in a chaise lounge chair. And any type of chest pain. If a woman presents in your area, work environment, with these symptoms, they go to the front of the line and they should be investigated for cardiovascular disease until you can totally rule it out. So prompt, concerned, and immediate assessment of the patient. Here are some concerning assessments, and I know that these vary, but this is from CMQCC. With a resting heart rate greater than 110 beats per minute, systolic blood pressure greater than or equal to 140, respiratory rate greater than or equal to 24, and O2 sats less than 95%, any type of murmur or crackles in lungs or suspected pulmonary edema. Here's the thing about the pregnant woman, and where sometimes we don't, as an adult patient presenting, we think, oh, well, our older populations are adults. Sometimes this is a norm for them, or we're not really concerned. But pregnancy puts a higher alert with these conditions, so we really need to pay attention to that. So how do we diagnose cardiovascular disease in the pregnant woman? Well, we can do an EKG, BNP, which we'll talk about in the next slide, an echocardiogram if the BNP is elevated, a chest X-ray. However, be aware that pulmonary edema or changes on the chest X-ray may be misinterpreted if the root cause is not investigated and pregnancy conditions aren't considered. A new diagnosis of asthma is highly unusual for an adult patient and especially in the pregnant woman. So this is where a consult with the OB provider, maternal fetal medicine, can be really beneficial and give us a new perspective. So a BNP, some of you are familiar with BNPs because you work in the adult cardiac area and you see and you're familiar with this test. In obstetrics, we're not quite so familiar with it, but it's a neurohormone that is secreted predominantly by the cardiac ventricles, and it's in response to volume expansion or pressure overload. So may indicate cardiomyopathy or work overload in the heart. The normal level, CMQCC considers anything less than 100 normal, where some cardiologists will say anything greater than 500 is indicative of heart failure. So BNP levels are higher predictor values of cardiomegalia or cardiomyopathy compared to chest X-ray, especially in that pregnant woman, and if she has any kind of hypertensive disorders. So what happens if she comes to your unit and you order the test and the BNP is normal? Well, if the pregnant patient or the postpartum patient, and we're talking about up to maybe 5 months to a year after delivery, has signs of pulmonary edema and the BNP is normal, it may suggest the lack of congestive heart failure or pump failure. So we need to look at the root cause of that pulmonary edema. And in this patient population, we need to consider non-cardiogenic pulmonary edema. This condition can occur within our pregnant or postpartum women who have had any kind of hypertensive disorders in pregnancy, because the valve cells become very leaky. That increase in plasma escapes out into the tissues and part of, and the lungs spaces too. So the fluid escapes from within the confines of the vessel to the surrounding tissues. So when a woman presents in those areas with pulmonary edema, the first thing we have to rule out, could it be cardiogenic? Then our BNP is elevated and we'd follow up with an echo. If she still has pulmonary edema, it's non-cardiogenic. Is there a root cause due to her history of hypertension disorders in pregnancy or postpartum? So these are really great podcasts. I love Stephanie Martin. She's maternal fetal medicine. She talks about peripartum cardiomyopathy, the fundamentals, and cardiac disease in pregnancies. Really great information. She dummies it down for me. I can really understand it, and I've listened to her podcast over and over again. But this gives really a simple and terrific explanation when we talk about cardiac disease in pregnancy. So I'd really encourage you, if you want more information, to listen to the podcast Clinical Concepts, either on your computer or on your phone. So prompts for further assessment in pregnancy and postpartum for cardiovascular disease when she presents to your unit. Again, does she have worsened levels of exercise tolerance or daily living, unexpected fatigue, chest pain, palpitation, dizziness, new onset cough of wheezing? Does she have leg edema? In the postpartum period, all those symptoms should be improving. They shouldn't be getting worse. How does she sleep? How many pillows does she use to sleep? Where does she sleep? Failure to lose weight or unusual weight gain, and how much? How much is she urinating? A history of cardiac or pulmonary conditions. Does she use substances or cigarette use? And I think this is an important concept that we need to remember, that some of the worst outcomes have been with people that have sought care in multiple places. They have not been heard. Their symptoms have not been attended to. And so as their symptoms increase, they end up not in a great place. So we really need to listen to people and also investigate where they have been throughout the healthcare system in regards to seeking care. And as a reminder, just normal pregnancy and postpartum physiological changes are symptoms that people will have, and then within cardiac disease. So these are some things that you can consider. And then the CMQCC does have a cardiovascular disease assessment or algorithm for both pregnant and postpartum women. They're red flags, and these red flags should prompt us to have evaluation and or hospitalization for these symptoms and consultation with both our maternal fetal medicine. And if you work in an area where you don't have a maternal fetal medicine, then you can contact them via phone. Yeah, the obstetrician or primary care provider, and then cardiologist also. So shortness of breath at rest, that severe orthopnea, using more than 4 pillows or sitting up in a recliner, inability to lie flat, the resting heart rate. Now they give a resting heart rate of greater than or equal to 120 beats per minute, resting systolic greater than or equal to 160. And then respiratory rate greater than or equal to 30. And then our oxygen sats 94% or less, with or without personal history of cardiovascular disease. And in the OB world, also, we really do promote to be an overachiever with the O2 sat in the pregnant woman at 95% or greater, so that she can perfuse that fetus. And then personal history of cardiovascular disease without red flags. It does prompt you to have consultation with both maternal fetal medicine and then cardiology and the primary provider. So this is a little bit more in-depth algorithm, and it combines both symptoms, vital signs, risk factors, and physical exam, and it leads you down the path of whether or not, if all those things are present, consulting the maternal fetal medicine and cardiology. And then if she has symptoms suggestive of heart failure, any of those things, obtain an EKG and BNP and echo, all those things. So this is available through the California Collaborative. This is an organization that's been founded since the 2010s, 2015, and all this information is available to people free of charge. You can print this up, post this, and have this in your wheelhouse concerning cardiovascular disease and pregnancy. So here are some key points. Symptoms related to physiological changes of pregnancy, they should be improving in the postpartum period. They should not be getting worse. We need to listen and hear people that come to our department, our unit, whether that be an urgent care, emergency department, or return to labor and delivery. Any visits to those departments with shortness of breath should raise suspicion for cardiovascular disease and should be investigated with blood work and then possibly echoes. Women of childbearing age should be questioned about recent pregnancies in addition to their last menstrual period. Postpartum dyspnea or shortness of breath or new onset of cough is concerning for cardiovascular disease. And new onset of asthma is rare in adults. Bilateral crackles on lung examination are most likely associated with congestive heart failure. And then the other important part is improvement of shortness of breath with bronchodilators does not confirm the diagnosis of asthma, because congestive heart failure can also improve with bronchodilators. Likewise, a lack of response to those bronchodilators, should really prompt the entertainment of a diagnosis other than asthma, which would lead us back to cardiovascular disease. So future risk and discharge education, once the woman is out of danger, and this is really an important, and even I think for every woman that has had any kind of hypertensive disease during pregnancy, to be aware of the symptoms to watch for in late pregnancy, and then also of these symptoms that don't go away. But it does reiterate our key points here. Any woman can develop heart disease in pregnancy or postpartum, but women who are higher risk, who have prior heart disease, are over 40, have preeclampsia, are high blood pressure, hypertension, are African American, are obese. It puts them at a higher risk. It's pretty much similar to our gestational diabetes patients in pregnancy. We used to think years ago that once they deliver, they were out of the woods for diabetes, and research has showed no, it puts them at a higher risk for different types of diabetes. And this plays true with hypertension disorders in pregnancy. It puts them at a higher risk. So we need to be aware and inform women to be seen by providers for symptoms and then also ongoing care on a yearly basis. And just more information and resources. There's the Council on Patient Safety and Women's Health, safe healthcare, for every woman. And these are other resources from CMQC that I mentioned. And then there is a Preeclampsia Foundation that both informs the layperson and medical providers. It's a great website for free education, but I also think it's a great website because it also informs laypersons of preeclampsia to get the word out there. So through education, recognition, and listening to our patients, we can really make a difference. And I thank you very much for listening to this content and hope you can use it in your practice. The following slides just review our references for this module.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.